Polymyalgia rheumatica. A 68-year-old female presented to the clinic with a 3-month history of generalized muscle pain, particularly in the shoulders and hips. She reports morning stiffness lasting over an hour, which improves as the day progresses. She denies any recent trauma or vigorous physical activity. Her medical history includes hypertension and osteoarthritis. You are the medical officer in a GP clinic. Take a focus history, perform an appropriate examination, provide differential diagnosis, and recommend relevant investigations. Key points for history. 1. Pain characteristics. Onset, duration, and progression of symptoms. Location: shoulders, hip, neck. Severity and impact on daily activities. 2. Morning stiffness. Duration: typically more than 1 hour in polymyalgia rheumatica. Pattern of stiffness improvement. Associated symptoms: systemic, fatigue, fever, weight loss. Jaw claudication or visual symptoms. Example: blurred vision, headache, suggestive of giant cell arteritis. Impact on the activities of daily living. Difficult dressing, rising from a chair, or combing hair. Relevant past medical history. History of autoimmune diseases, rheumatological conditions. Example: rheumatoid arthritis, osteoarthritis. Vascular condition. Screen for temporal arteritis. Medication history. Current medication, recent corticosteroid use, or any other drugs causing myalgia. Red flags: night sweats, lymphadenopathy for malignancy, recent infection or travel history. Key point for examination. General inspection. Assess for signs of distress, systemic illness, or weight loss. Musculoskeletal examination. Tenderness and pain on palpation of the shoulders, neck, and hips. Limited range of motion. Active and passive. Temporal artery examination if GCA is suspected. Palpate temporal arteries for tenderness, thickening, or absent pulse. Neurological examination. Rule out muscle weakness. Polymyalgia rheumatica does not cause through weakness, but rather stiffness and pain. Reflexes and sensation testing to exclude neurological causes. Vital signs. Check for fever. Low-grade fever may be present in polymyalgia rheumatica. Differential diagnosis. 1. Rheumatological. Rheumatoid arthritis, systemic lupus erythematosus, fibromyalgia. 2. Neurological. Polymyositis or dermatomyositis, myasthenia gravis. 3. Endocrine or metabolic. Hypothyroidism, vitamin D deficiency, statin-induced myopathy. 4. Infectious. Post-viral myalgia. 5. Malignancy. Paraneoplastic syndrome. Example due to occult malignancy. Relevant investigations. Blood test. Inflammatory markers. ESR, typically more than 40 mm per hour. CRP. Autoimmune panel. ANA, rheumatoid factor, anti-CCP to exclude rheumatoid arthritis. Muscle enzymes. Creatine kinase to rule out myositis. Thyroid function test to exclude hypothyroidism. Imaging. Ultrasound or MRI. Evidence of bursitis or synovitis, supportive of polymyalgia rheumatica. Temporal artery ultrasound or biopsy if giant cell arteritis is suspected. Other test. Complete blood count. Rule out anemia or malignancy. Liver and renal function test. For medication baseline. Vitamin D and calcium levels. Clinical management plan. This case is designed to evaluate your ability to differentiate polymyalgia rheumatica from other conditions, recognize the potential overlap with giant cell arteritis, and order appropriate investigations. Management includes corticosteroids.